I want to bring greetings on behalf of the Chancellor's Office, the Provost's Office, who support this center, and the School of Social Work, where we are housed, and do a lot of collaborative work in the department and across the university. So welcome. What an important topic that we have this morning. We're talking about Black infant health, Black babies matter. And I think in the past year, so many issues have come to light around racism in America. And I think for white America, mainstream America, some of this was like shocking revelation. But for Black America, we know that these issues and injustices have been ongoing throughout our lives, throughout our generations. And one of those key areas is in infant health and in maternal health as well. If you think about your lineage or yourself in the Black community, you probably know someone who's experienced something very difficult in this space. And we're very excited to have leading experts nationally today to talk about this work and to talk about some of the things that people are doing to increase just our survival and what we can do to ensure the livelihood of our babies and their mothers and our families. And so we have an award-winning leading scholar in the country coming today. The paper that she's going to discuss today just won the Casarelli Prize for Behavioral and Social Science Research from the National Academy of Sciences. And this is awarded for uncompromising scientific standards and dedication for advancing scientific knowledge. And this is a fantastic paper and a fantastic speaker. But I'm getting ahead of myself because my job is not to introduce our speaker. My job is to introduce the introducer, who is amazing in her own right. And I'm very excited to introduce Dr. Dara Mendez. She's an assistant professor in the Department of Epidemiology and Behavioral and Community Health Sciences. She is also the interim director of the Center for Health Equity at the University of Pittsburgh and the Graduate School of Public Health, our co-sponsor for this event. She's an affiliate faculty member of the Geoinformatics Laboratory in the Center for Latin American Studies at Pitt. She completed her postdoctoral training as a Kellogg Health Scholar and earned her MPH and PhD in maternal and child health with a focus on epidemiology at UNC, University of North Carolina, Chapel Hill. She has a BA in sociology, anthropology, pre-med at Spelman College. Dr. Mendez applies a variety of methods and approaches in her work as it relates to the complex intersections between racism, multiple forms of oppression, stress, and place in understanding Black maternal and infant health, as well as racial, ethnic inequities in pregnancy, birth, and women's health. Dr. Mendez is a national expert and collaborates with community-based and governmental agencies focused on maternal and child health, reproductive justice, and broadly health equity. I'm very excited to have her with us today. Dr. Mendez, how are you?
I'm great. I'm grateful to be here with you all. Thank you for that introduction. Thank you for the opportunity to collaborate. The collaboration and co-sponsorship between the Center for Race and Social Problems and Center for Health Equity is tremendous. And I'm really excited to be here, to be able to introduce a friend and a colleague. But before I tell you about how wonderful this person is, who we have coming up to speak, I wanted to lift up and just share a little bit about some of the local partners doing some of the work that speaks to inequity in pregnancy and maternal health, that really speaks to addressing and undoing racism and forms of oppression here locally. So one, I wanted to first lift up the Center for Social Race and Social Problems for sponsorship and funding for some pilot work with collaborative partners with Healthy Start, and really addressing issues around racism and pregnancy and birth. They're a leading partner here locally, and we've been engaged in work across Allegheny County with a number of partners in the maternal child health space. and reproductive justice space to really uncover and understand the ways in which our local policies, programs, organizations, and funding structures are attentive to the needs of Black women and femmes in the ways that they are not, right? And so we are in the middle of that very important work. And then I also want to mention the Center for Health Equity and colleagues and staff who have, really made this work possible, who've been conducting a number of both studies as well as policy and advocacy endeavors, as well as teaching and training around addressing equity and oppression across both the University of Pittsburgh and the county. And many of these partnerships are, critical to the work that we do. And one of the really amazing partners that I have across this country is Dr. Rachel Hardeman. Really grateful for her dedication, lack of compromise, advocacy on so many levels. So it is with pleasure that I have the opportunity to introduce you to her today. Dr. Hardeman is a tenured associate professor in the Division of Health Policy and Management, University of Minnesota, School of Public Health, and the Blue Cross Endowed Professor in Health and Equity, Racial Equity. A reproductive health equity researcher, she applies the tools of population health science and health services research to elucidate a critical and complex determinant of health equity, inequity, racism. Dr. Hardeman leverages the frameworks of critical race theory and reproductive justice to inform her her equity-centered work, which aims to build empirical evidence of racism's impact on health, particularly for Black birthing people and their infants or babies. Dr. Hardeman's research includes a partnership with Roots Community Birth Center in North Minneapolis, one of 5 Black-owned freestanding birth centers in the United States. Her work also examines the potential mental health impacts for Black birthing people when living in a community that has experienced the killing, I'm sorry, I lost my place, of an unarmed Black person by police. And she has been published in a number of journals, is known nationally for really, moving our conversations forward on the topics of culturally centered care, police brutality, structural racism as fundamental causes of health inequities. And you heard about the paper and the award that she recently received, and she is also active locally and nationally with organizations such as the Minnesota Maternal Mortality Review Committee and Board of Directors for Planned Parenthood of the North Central States. And her overarching goal of her work and body of knowledge is to really, address structural racism in tangible ways, identify the opportunities for intervention, and dismantle the systems, structures, and institutions that allow inequities to persist. And so without further ado, I welcome and introduce to you Dr. Rachel Hardeman.
Thank you, Jason and Dara, so much for the warm welcome and the introduction. I'm so happy to be here. I've long admired the work of, your work, Dara, and I'm grateful to call you a friend and collaborator, and also look forward to future partnerships and collaborations, both with, so the School of Social Work and the Center for Health Equity at University of Pittsburgh. So I'm going to get my slides shared so we can get started. Because I want to make sure that we have enough time for questions and discussion, because I find that's the sort of best part of being able to do this in the virtual spaces that we find ourselves in these days. So I'm just going to jump right in. Today I'm presenting on my research around physician-patient race concordance and disparities in birthing mortality for newborns. Oops, sorry about that. I want to acknowledge, my co-authors, Brad Greenwood, Laura Wang, and Aaron Sojourner, who, this paper and the work that we've done in this particular study has been a labor of love. It was not work that was funded, and we dug in and spent a great deal of time producing this study. And so I am greatly appreciative for their collaboration. I don't have anything to disclose today or any conflicts of interest. So as you heard from my bio from Dr. Mendez, I conduct research that seeks to manifest racial justice so that all people, and especially Black women and girls, can live their full greatness and glory. And right now, that's not happening. And so I want to start by centering us on what is important, and that is the lives lost and the injustices faced by too many Black moms, Black babies, and Black families. And I wrote the words you see on this slide in the aftermath of George Floyd's death, which happened just a few blocks from my childhood home. And I'm going to read it now and ask that we reflect on these words and take a moment to lift up both the Black lives lost, the Black babies lost that I'll talk about in this study, the Black babies that will grow up without a mother, the Black women like Breonna Taylor who will never have a chance to become a mother. So I wrote, "Mama," George Floyd called out, face pressed against the pavement with the knee of a Minneapolis police officer in his neck. "Mama, I'm through," Mr. Floyd yelled. George Floyd's cry for his mama resonates deeply with all of us. We all know what it feels like to need our mom in times of fear and distress. Yet there's something else haunting and painful in Mr. Floyd's words, a cry for help so profound it summoned all Black mothers in America, shaking us to our core, evoking images of our beloved Black sons and Black daughters stolen from us too soon. Stolen life and stolen breath, whether from police violence or entrenched inequities in maternal and infant health and mortality, leave far too many Black people calling out for their mama. So as we take a breath, I'm going to jump into some background that I'm guessing many of those of you on this webinar today are familiar with, but in case you're not, I think we need to ground us in the reality of what we're grappling with as a nation. And that is that each year in the United States, 700 to 900 women die of pregnancy-related causes, which makes the United States the only developed country in the world with the highest and increasing maternal mortality rate. And what we know is that maternal mortality is a clinical, a public health, as well as a social crisis. Risk for maternal mortality is unevenly distributed. So with some populations bearing substantially greater risk. And among the groups at highest risk for maternal mortality are Black and Indigenous birthing people. So Black birthing people are 3 to 4 times more likely to die of pregnancy-related causes than white women, and that's regardless of education levels and socioeconomic status. And that's a statistic that I'm sure many of you have heard time and time again over the past few years as we've begun to pay more attention to this crisis in our country. I also just want to note that you'll find that I may use both the term women, pregnant women, and birthing person interchangeably throughout the presentation. Please know that I affirm all gender identities and recognize that not just women give birth. And a lot of the language choice in my talk is tied to how the literature in a particular study has decided to use that language. So in addition to maternal mortality, we have infant mortality. And we know that preserving the lives of newborns has been a longstanding issue in public health, as well as in social policy and humanitarian endeavors. High infant mortality rates are generally indicative of unmet human health needs in sanitation and medical care, nutrition and education. And historical demographers estimate that in 1850, enslaved infants died at a rate 1.6 times that of white infants. Whereas in 2016, CDC data shows that Black infants have a mortality rate that's 2.3 times higher than white infants. So inequities in infant mortality have persisted for as long as we've collected data. And even as a country, as we've lowered the infant mortality rates in the US, that gap, that racial gap between Black and white infants has essentially, in many cases, gotten worse, and in some cases, at least stayed the same. So this Washington Post article describes the study that I'm going to share with you today around newborn mortality. And what we look at is if racial concordance between a patient and a provider, a clinician, matters for outcomes for Black infants. And I'll dig into the study in a little bit, but I wanted to sort of start with the historical context, because I think that the history is incredibly important. So while our findings may reflect, certainly reflect the current reality, the reasons behind this reality are steeped in a historical context that must be understood in order to begin to think about the ways that we want to, and are able to dismantle these inequities that are deeply baked in and entrenched in our society. So we have to start by learning about, understanding, and accepting the United States racist roots. And that phrase comes from a piece that I wrote in 2016 with colleagues just after Philando Castile was shot and killed by a police officer about a half mile from my office at the University of Minnesota. And our goal with this piece was really to ensure that our colleagues, so clinicians and researchers, recognize that we can't live our lives as though we don't have a role to play in dismantling structural racism and supporting Black lives. And so we wrote this call to action, laying out the first steps towards dismantling the systems of oppression that keep Black communities from thriving. And that is that first step of learning about and understanding and accepting the United States racist roots. And that means understanding that in 1619, a group of 20 Africans were sold into bondage in Jamestown, Virginia. And thinking about how current inequities in infant mortality and in maternal mortality are inextricably linked to the year 1619 and all those in between. So these timelines are a reminder of how deeply ingrained our history is and all of the ways that white supremacy has taken new shapes and forms, frankly, in order to maintain the status quo. So what we see here is that Black enslavement comprised 60% of our country's history, and then Jim Crow, so those state and local laws that enforce racial segregation, made up 20% of our history. And then, although Black Americans won the right to citizenship in the wake of the Civil War, the right to equality was not granted until about a century later. And even then, most Black folks were not allowed to exercise that supposed right. And today what we see is that white supremacy shows up in different shapes and forms, whether it's mass incarceration, the war on drugs in the 80s, police violence, and in many other social issues that plague our society. So, while we might argue over how different America might have been had our country never embraced white supremacy and race-based slavery, we certainly can't argue that this history has not fundamentally shaped who we are today, and also just how much work it's going to take to undo the ways in which these ideologies have framed every institution that we work in, we live in, educate our children in, and offer healthcare in. So in order to learn about and understand and accept the United States racist roots, we have to explore the origins of racist ideas. So in Ibram Kendi's book, Stamped from the Beginning, which is his first publication prior to How to Be an Anti-Racist, which is a book I think a lot of folks are familiar with over the past year or so. So in Stamped from the Beginning, he suggests that discriminatory actions wrought by self-interest come first. Then the racist ideas are developed to justify them, and they spread. So in other words, racist beliefs were created, right, to prop up the institution of slavery and justify the poor treatment of Black people. And then eventually the rationale for Black oppression multiplied in the colonial era and the early slaveholding republic. And these ideas like African slaves, Black slaves were, our enslaved folks were hardy and made for work, or that they couldn't feel pain or had thicker skin, were all constructed to justify their enslavement. So here's an example of when racist beliefs become racist actions. So James Marion Sims, who's known as the quote unquote father of modern gynecology, took racist beliefs and translated them into racist actions, conducting research on enslaved Black women without anesthesia. And the racist belief, or one of the racist beliefs at the foundation of his practice, was that in addition to their status as enslaved people, Black women or Black birthing people were considered appropriate subjects for his experiments based on the widespread belief that Black people experience less pain than white people. And that's where this racist belief or narrative of obstetrical hardiness comes from. And it became influential racial folklore within medical theory and in medical practice because it harmonized, right, so well with the racial ideology that had already shaped Western thinking about racial differences and allowed for the justification of Black bodies to be enslaved and Black bodies to be used for research. And so this is a picture of Anarcha, who was a 17-year-old enslaved woman who was one of James Marion Sims' primary research subjects. And he actually experimented on her for about 4 years and 30 operations before he, with her body, declared that he had perfected his methods. And I also think it's important to note that from the perspective of slave owners, this development, James Marion Sims' development, research success, right, was seen as notable because it meant that healed slaves could retain their economic value. So when Princeton sociologist Ruha Benjamin says that, quote, racism is productive, she's absolutely right. Furthermore, in our article, a recent article called Stolen Breaths, my colleagues and I state, we got here because we believe, or because we live in a country established by indigenous dispossession and genocide. Because slavery and the racial ordering of humans and goods, it constructed a political economy predicated on devaluing Black labor, demeaning Black bodies, and denying Black humanity. We've got here because stolen lives and stolen breaths are profitable, and we work in systems that continue to reap the gains. And I share these words because I think it's important as I dig into our study to think about this within the context of the research that I'll share with you today, because I think certainly it's going to have an impact in what we do to change the narrative and change the system. So the next part of our call to action in that 2016 piece was that in addition to learning about this history, we have to learn and understand how racism has shaped our narrative about health disparities. For example, the same beliefs used by Sims and others to justify the experimentation on Black bodies, so these ideas around Black women being hardy or not feeling pain or having thicker skin, they show up in how medicine is practiced today. So there was a study published in 2016 that found that 50% of white medical students and residents endorsed these same beliefs. The ones that were used to rationalize, are used as a rationale for slavery, and that these same physicians or trainees who endorse these beliefs were also more likely to score highly on the implicit association test that measures automatic racial bias. So in thinking about how racism has shaped the narrative of health disparities, let's consider the notion of obstetrical hardiness and ask, how has a racist idea, belief, or action such as obstetrical hardiness shaped the narrative about maternal and infant health inequities? So obstetrical hardiness in 2021 might not show up in the same explicit ways that we saw it show up with Anarcha and many other Black enslaved women, but I offer this information to say that those underlying narratives and beliefs are still persistent and still sort of lingering under the surface and impacting how Black women, Black birthing people get care or don't get care. So we see that Black women experience disparities in pain management in the postpartum setting that can't be explained by having less perceived pain. We see that white women are asked to assess their pain more often than women in any other racial or ethnic group in the postpartum period. We see that Black women were evaluated for pain less frequently, but also had higher pain scores and received less pain medication than their white counterparts. And often those differences didn't go away when considering other clinical factors, which suggests that racial inequities are the result of a difference in the way that care is being delivered. Another example of a racist narrative that shows up in maternal and infant healthcare delivery is illuminated in this study put forth by myself and my colleague, Dr. Laura Atanasio, a couple of years ago. And in it, we sought to investigate birthing people's experiences of declining or refusing procedures in maternity care. So specifically examining the association between a birthing person's report of declining a non-life-threatening medical procedure during the childbirth and postpartum period and perceptions of discrimination, and whether those whether or not declining a procedure was differentially associated with perceived discrimination depending on race and ethnicity. And what we found in this national sample is that women who reported having declined care for themselves or their infant during the childbirth hospitalization phase were more likely to report poor treatment based on their race. And we see an increase in odds of perceived discrimination due to a difference of opinion with a healthcare provider. And that was significantly larger in magnitude for Black compared to white women in our sample. And I think what this suggests, among many things, right, is that in the context of childbirth care, women pay a penalty for exhibiting behavior that may be perceived as uncooperative, and that this penalty is certainly greater for Black women in our sample. And the potential consequences of declining something, or being empowered enough, right, to decline a procedure that you're not comfortable with, is worse for Black women who already have to expend a great deal of effort to manage their image during healthcare encounters in order to avoid the stereotypes and racist narratives around being aggressive or being the quote unquote angry Black woman. So now I want to shift away from sort of that historical context to discuss specifically, the study you heard about at the start of this presentation, and what's happening sort of in the current context. One solution to closing some of the racial health inequities in maternal and infant health has been to focus on diversifying the healthcare workforce. And we can talk later about how well those efforts have been going over the years. That's not going to be my focus in this moment, but I want to talk about why that matters, why a diverse healthcare workforce matters, and specifically about racial concordance. But before digging into racial concordance specifically, I'll just share there's a pretty large body of concordance literature generally. So we see that there is benefits of, and concordance meaning whether it's gender-based, race-based, or other sort of care, so socio-demographic characteristics. So broadly, we see that the benefits of female leadership for young women working in large law firms and things like that. We see leniency in enforcing regulatory compliance when the inspectors and their targets share a similar background. We see that academic performances increase with shared race, so teachers, and we see incarceration rates increase for defendants who are paired with judges who are of a different race. And I think none of that is surprising to those of us on this webinar today, particularly those of us who study health inequities or inequities in race and social problems in some way, shape, or form. So the concordance literature in medicine and healthcare, has shown us that racial and/or gender concordance certainly has an increased rapport. We see a greater satisfaction reported for patients of color who are seen or have a clinical encounter with a physician that shares their racial identity and racial background. We see that gender concordance increases the willingness of women to participate in preventative screenings. There's studies that show that racial concordance increases healthcare utilization in under-resourced communities. There's newer literature emerging around clinical, concordance having an effect on clinical care outcomes. A recent study actually out maybe a month or so ago actually found that total healthcare expenditures were lower. They looked at MEPS data and found that total healthcare expenditures were lower among Black, Asian, and Hispanic patients who had a race concordant clinician. And then there's a group of economists that have looked at the role of Black doctors in reducing the Black-white male gap in cardiovascular mortality, and found that racial concordance could reduce mortality by about 19%. Also, a great deal of the literature around racial concordance in healthcare settings has told us that communication between the patient and the physician or clinician is key. So in a racially concordant, this idea that in a racially concordant relationship, being able to communicate with ease and in a way that feels, culturally centered, it feels right for that person is incredibly important. And I think that I have that bolded, the communication piece bolded, because it's an important component to consider as you mull over the findings of our research paper. So in this work, we examine whether or not patient-physician racial concordance influences mortality during a newborn's first admittance to the hospital. So our theoretical hook here is that, as I just said, there's considerable work examining the benefits of concordance in academic, business, judicial, and medical settings. There's also considerable work highlighting the disparities in outcomes experienced by Black newborns and birthing mothers. And so our goal here is to, connect those two literatures and to really think about what this means in the context of newborn mortality. And the compelling piece, I think, to this work is that going back to that communication piece that has been so prominent in the racial concordance literature. In this case, we're talking about newborns who aren't able to communicate, right? So that can't be a part of what's happening within this, within the clinical encounter to dictate whether or not, how outcomes are predicted. So our data come from the state of Florida's Agency for Healthcare Administration, the AHCA, and they provide a census of patients admitted to Florida hospitals between 1992 and 2015. So we started at 1992 because prior to that, patient race is unavailable. And we stop in the third quarter of 2015 because that's when the coding shifts from ICD-9 to ICD-10. Patient data includes race, comorbidities, outcomes, the hospital they were treated, and much, much more that I won't go into for the sake of time. The physician data includes attending physician in charge of the patient's care, so the name, specialty certifications, date of licensure, information like that. Excuse me, inclusion criteria included the newborn had to be coded as a baby born within the facility or in the initial admission of an extramural birth infant to an acute care facility within 24 hours of birth. And then all newborns who were not white or Black and all physicians not coded as white or Black were dropped from our sample. So we focused solely on white and Black samples. We did do some sensitivity analysis with other races as well, but I likely won't have time to dig into that today. So the physician race was a really interesting piece of this study because just like most data sets involving physicians, the AHCA does not have an explicit coding of physician race. So to determine race, we did a lot of work. Well, I should say we had some incredible folks that did a lot of work. So we enlisted a team of 10 professional RAs, research assistants, to manually code physician race. So this team was able to identify photos of 8,045 of the 9,992 physicians in our sample. And photo sources came from physician rating sites like healthgrades.com, as well as hospital and clinic web pages, obituaries, affiliated organizations, board memberships, and on and on. And then before coding the AHCA data, each research assistant was given a corpus of 100 randomly selected high resolution standardized photographs of male and female faces of varying races and ethnicities between the ages of 17 and 65. And this is a method that has been validated in prior work. And so the 4 RAs that demonstrated 100% accuracy in that with that test sample were retained and then assigned a portion of the physicians and instructed to subsequently code for physician race, Black, white, Hispanic, East Asian, South Asian, or Middle Eastern. And then following that coding, each section was then reassigned to a different research assistant to confirm consistency and intercoder reliability. And there were actually no discrepancies in identifying accurate physician photographs. And there were about 175 instances of discrepancies in racial coding that were identified. And then the team met to discuss the coding until there was 100% agreement. And each of those 175 photographs was then sent to a third research assistant to ensure agreement. And 10% of the whole sample was randomly pulled and sent to a new and separate research assistant to determine any disagreement in the coding of physician race. And at that level, there were no disagreements that were identified. And then finally, to obtain convergent evidence, we had an independent set of research assistants that individually assessed surname of each physician. And this surname was set, or the surname set was then cross-listed with public lists of Black people who have held leadership positions in the business workforce. And the coding of surnames was also cross-checked with coding based on physician photographs, providing us with greater assurance that we didn't omit any Black physicians or falsely categorize a physician as Black. So we did a lot of checks and balances in this process. And you know, I think it also speaks to like how much life would be easier if we actually just collected physician race in our data sets. I think it's an important, certainly these findings speak to the importance of having that information as a key part of the research. Here's a list of some of our controls. I won't go through the whole list, but you know, certainly we thought about insurance coverage, the common comorbidities, and several other things that can be found in the supplemental materials of, excuse me, for the paper. Oh, I was also going to say, we got an email after the paper was published asking about the inclusion of major congenital and chromosomal anomalies as a comorbidity, and we did run those models and found that the results remain consistent as we had published them. So what we see, and I apologize, I know these tables are number heavy, and I'll do a nice summary slide that actually kind of offers the take home points. But what we see here is that the physician Black coefficient implies no significant difference in mortality among white newborns cared for by Black versus white physicians. And that's in these columns 1 to 5. And then in the simple model, absent controls, we see that the patient Black coefficient indicates that under the care of white physicians, Black newborns experience 3 times or triple the in-hospital mortality rate of white infants. And under the care of white physicians, the white newborn mortality rate is 290 per 100,000 births, as implied by that constant term 0.290, and Black newborn mortality is estimated at 894 per 100,000 births. So then we asked, you know, what about medical complications? You know, because one explanation of the effect could be that Black physicians may be more attuned to the challenges Black newborns face. And you know, this is certainly intuitive, as the generation of medical knowledge in the US often focuses on a white patient pool and a whiteness as sort of the standard in how we compare outcomes. So we thought, what happens if we split the sample based on the presence of a single comorbidity? And so in doing so, we, you know, replicated our earlier estimations of each subsample. And we find that the estimated effect of concordance is statistically significant at conventional levels in the larger subsample of more complex cases. And that's this column 8 here. And similar but less precise for patients without comorbidities, and that's this column 3. And among cases with more than 3 comorbidities, the estimate is larger, but it's actually less precise. So then another possibility to consider is that different hospitals might be performing at different rates based on the count of newborns that they're treating, and that certainly has been documented in previous work. And you know, it's possible that on one hand, if there's diminished access to care for Black mothers, they may not have access to higher quality hospitals. On the other hand, hospitals treating a lot of Black newborns may become particularly skilled at managing these cases. So our empirical strategy to test this was to split the sample at the median number of Black newborn cases in the hospital quarter. And as we can see here, the benefits of concordance only manifest in hospital quarters that have a greater number of Black infants born. And that's, sorry, I'm just gonna load all of this before, oops, sorry about that. Got ahead of myself. So we can see in columns 3 and 8, so column right here, and then in column 8 as well, that the mortality penalty for Black newborns treated by white physicians is actually 56% larger in hospitals that have a larger number of Black newborns. And this suggests that all else equal, that Black physicians are not performing better as the number of Black newborns increases. Instead, it appears that white physicians are underperforming. And that's what the numbers in columns 4 and 9 here indicate for us. We are also interested in looking at what was happening with Black birthing mothers. So like newborns, we know that Black birthing mothers in the United States suffer dramatically higher mortality. We discussed that early on in the talk. And so we wondered if the benefits of concordance replicate to the birthing mothers in Florida over the same time period. And so here we're focusing on the obstetrician instead of the pediatrician. And so we updated comorbidities based on those relevant for maternal health outcomes. And but unfortunately, data restrictions did prevent us from being able to link an individual birthing mother to an individual newborn in this particular sample. So consistent with prior work, we see a penalty for Black birthing mothers in general. Although the base mortality rates are an order of magnitude that's quite a bit lower than for infants. So, what we see is that among birthing mothers cared for by white physicians, Black mothers experience an additional 14 deaths per 100,000 births, in comparison to white mothers' mortality rate, which was about 7 deaths per 100,000 births. There is no difference in mortality rates based on physician race, however. While the interaction of patient and physician race is directionally consistent with concordance benefits for Black mothers, that estimate actually was never statistically significant, which was a surprising finding, I think, for our team, and something that we are looking forward to digging into further as we continue to develop this work. And I welcome thoughts and ideas in that space. So this is the paper in one slide. This is how we would summarize sort of the most important or key finding here is that we observe a robust racial concordance benefit for Black newborns as compared by that physician Black patient Black interaction. And then under the care of white physicians, Black newborns experience 430 more fatalities per 100,000 births than white newborns. And then under the care of Black physicians, that mortality penalty for Black newborns drops to 173 fatalities per 100,000 births. So that's a difference of 257 deaths per 100,000 births and a nearly 60% reduction in the racial mortality difference when a Black newborn is cared for by a Black physician. So again, to summarize sort of the key findings of this complex paper, first that, not surprisingly, Black infants experience inferior health outcomes regardless of who's treating them. And that's, sort of fundamental to the issue that we're grappling with around the racial inequities and infant mortality. However, the clinical penalties for Black newborns treated by Black physicians are cut in half. Second, we see that these benefits accrue more sharply in more medically complicated cases. So the more medically complicated a newborn is, the more beneficial it is to have a Black provider caring for them. Third, these effects are more pronounced at hospitals that deliver more Black newborns. And then finally, again, we observe no effect of racial concordance on mortality for birthing mothers. And I think there's a lot of reasons to explore for why that was the case. So what are the implications here? I think there's a lot to talk about. One conclusion we've heard is that these findings mean that Black newborns should immediately be funneled to Black physicians. And while racial concordance is incredibly important, as this paper and many other studies have shown, going back to that diversity of our healthcare workforce, it's not necessarily a feasible solution, at least not right now. The physician workforce is disproportionately white. And I also think it avoids the foundational concern of resolving the inequities in care that are showing up in how white physicians are possibly interacting with Black patients. And also, I think it doesn't address that historical context that's deeply embedded in in our healthcare systems that I, started this presentation discussing. We've gotten a lot of feedback from white physicians who are incredibly concerned about these findings, some who are incredulous and want to, and say, how dare you suggest that I'm harming, Black infants. And, we've been really clear, my co-authors and I, about the fact that this isn't about individual physicians doing harm to Black babies. This is about the fact that we are working within a system and a structure that from its start was not created to value Black life. And so if we can't reconcile that, we're going to continue to see these sorts of outcomes perpetuated in the care delivered, intentional or not. So I think a key open question to consider based on this work. And again, one of the other questions before I jump into this, I should say, is that we often get the question of, so what's happening? Why is this happening? And so, I'm always clear, we didn't study the mechanism behind this. That's certainly worthy of study and something that I look forward to digging into. And, we certainly have, in the way that, even Dr. Mendez's work and others across, other scholars across the country have been, asking these sorts of questions. But I think, considering currently and urgently what actions can be taken by policymakers, administrators, and physicians to ensure that all newborns are receiving optimal care is incredibly important. And that level of analysis and engagement has to happen both certainly at the physician individual level, that's incredibly important, but as well as within teams and what those dynamics look like, how hospitals are allocating resources. But also, I think we have to be thinking about this brought outside of the hospital system and within our communities and our states and our nation to really be able to address structural inequity and structural racism at all levels. So some ideas around the path forward as I close out this presentation is, certainly the call to continue the diversification of the medical or healthcare workforce. Hospitals have to be thinking about, and some are, I think we're seeing more efforts in this space in the past year, certainly, and investing in efforts to reduce biases and explore and disrupt racism and explore their connection to institutional racism. So really thinking about what organizational change looks like within healthcare delivery systems, education and awareness, and not that we're going to educate our way out of racism. I think education and awareness are incredibly important, but they are one part of this sort of complex solution that has to be formed in order to really address these issues. Certainly some of that looks like the need, is the need for medical education to be, for anti-racism training to be embedded in medical education. So we're creating a healthcare workforce that is deeply knowledgeable and has the competencies to be able to address these issues head on. And then for those who are out of their training, education and awareness doesn't stop there. It's an ongoing thing. And I think thinking about the ways to tie the need for anti-racism training certainly to quality improvement and accreditation, and making it a medical competency is incredibly important. I also think, there's been some work on the certainly in the cross-race empathy gap, and really thinking about how we've been socialized to think about race and whose lives we value, right? I mean, it's, Black people are getting messages day in and day out about whose lives are valued and whose aren't. And, that it's inevitable that that's going to be, embedded in and deeply sort of part of the fabric of how we interact with patients. And so really addressing the cross-race empathy gap, I think has to be a part of the conversation as well. So in closing, as I said, this paper has been a labor of love. It's been incredibly controversial at times. And again, while we don't examine the mechanisms behind these findings, I do believe that understanding of the historical context, some of which I shared with you today, which is a drop in the bucket of, I think, what we need to be thinking about and understanding in that space, is incredibly important to understand how these outcomes occur and what those, and start to dig into the mechanisms behind it. We're certainly grappling with institutions that have not fully reconciled their racist past and that history. And we're grappling with a medical education system that has only begun to start the journey towards embracing anti-racism training and thinking about ways to embed it into all parts of the of medical training. So by doing the work in all of these spaces, we have an opportunity certainly to create a better future for Black infants and for all infants. And so I leave you with the words that we wrote in Stolen Breaths, that the choice before the healthcare system now is to show and not tell, that we say in Stolen Breaths that Black lives matter. And that includes the, showing and not telling that Black babies matter. So thank you. And I look forward to your questions.
Dr. Hardeman, thank you so much for that amazing talk. And I just want to, I want to thank you for the historical context that you put this in, because I think when we think about the history of racism in America, and even for many of us that feel versed in it, we think about, some of the overt things that happen, and we don't think about what's happening in hospitals or people that don't even get to go into hospitals. With this, and there are so many thousands, if not millions, of voices that your work is giving voice to throughout the history and the current reality. And I just want to say, be encouraged and keep going forward, regardless of who's in your face and opposing you. At least here we got your back. So
thanks.
Give us a call. Anyway.
I appreciate that.
For sure. I want to jump into Q&A, and if you have a question, please put it in the Q&A. And we'll get to a few with the time we have. We have a comment from Raquel Moss, and I apologize if I'm saying your name incorrectly. Having thicker skin is still believed in the medical field by quite a few medical professions today. So sad. And the question that emerges from that is, if you are a patient and you perceive that that's happening to you, what do you advise people to do in those situations?
That's such a hard question, because I'm constantly trying to balance like the immediate need, like for people to feel safe, and and leveraging sort of the materials that have been put forth around like helping to support particularly Black people and Black birthing people as they're engaging with the healthcare system, but also continue to put pressure on the system to change, right? Because it shouldn't be the job of a Black person to to do that work. But in the meantime, I also recognize that systems change is hard and it takes a long time. And so in the meantime, we have to keep accessing institutions that may be harmful. And so one of the things I always talk about, particularly in the context of childbirth, and I think Dr. Mendez has certainly done some of this work too around doula support, and but not just having even outside of birthing space, like having someone who is there with you, who can help advocate or even just listen and take notes, or pick up on some of the sort of things that might be going on in those interactions, and being able to help you, help support you both emotionally, but also to navigate those systems is incredibly important.
Mm-hmm. Yeah, thank you so much as well, Rachel, for all that you shared in your work. And a couple of things that you mentioned reminded me of, as you talked about the profit of racism and it being the fabric. And one of Toni Morrison's quotes is, "Racism will disappear when it's no longer profitable and no longer psychologically useful. When that happens, it will be gone." And so, one of the things that, I thought about as you were speaking, and even in your paper, is one of the frameworks that Dr. Donna Ian Davis puts forward around the framework of obstetric racism and some of the sort of layers. I know that wasn't sort of the focus, obviously, or implications for this particular study, but I obviously see the alignment and overlap for what she talks about in the aftermath of slavery and her chapters on that, and the ethnographic work and the experiences of families and parents who had children in the NICU and what they saw. So I guess this is more of a kind of a statement and a question as to whether or not some of that work, as it relates to the sort of framework of obstetric racism and what that might mean for your findings, as well as next steps as we think about structural interventions.
Yeah, I think Dr. Davis' work is incredible. If folks on this webinar haven't read her book, please do. It's really powerful. And I think the notion, the concept of obstetric racism is one that, is incredible. It's an incredibly important framing for what's happening and how we, both how we conceptualize, but also how we operationalize it. And I think, as I think about the future work, building from this study, that framework of obstetric racism is going to be incredibly important for digging into the maternal mortality piece, right? And, right now what we're seeing is that while, those maternal mortality rates are higher for Black birthing people, that association with concordance wasn't statistically significant. But I think that there's so many layered pieces there that need to be dug into, and leveraging, Danae's work, as well as Dr. Karen Scott's work, and building out the patient-reported outcomes of, patient-reported measures of obstetric racism is how we're going to be able to both dig into what's happening there, but also I think obstetric racism in particular is going to allow us or lead us towards sort of more, highlight those mechanisms behind the outcomes in a way that will be incredibly powerful.
Mm-hmm.
We have a comment that comes from the research community and Dr. Sharon Nelson Legault, and she says medical education must be based on empirical evidence. The empirical evidence must be generated by scientific methods that are based upon normative studies of all peoples. The scientific base of modern medicine is corrupted by racist ideologies that have infected its construction. The questions asked and answered reflect a narrow focus on the group controlling the scientific enterprise and persist through the practices of confirmatory bias. So I think the question that emerges from that is, what do we do? What can we do in the scientific community to fight the battles that need to be fought, to shift and validate the focus on racial biases and what it means for best practices?
Yeah, all of that is so real. And, I think something that a lot of Black scholars in particular have been, pushing back against and fighting back against for years. And I think I'm seeing, and I would be curious to hear, Dr. Mendez, your thoughts on this too, as we've worked to think about sort of particularly the measurement of structural racism and how to create an evidence base that often feels like, at least for me, I often feel like I'm creating an evidence base for things that I already know as a Black person, right? And as a Black woman, as a Black mom. But so much of that is not just about the generation of the knowledge, but also the shifting the paradigm around the methods that we use to generate that knowledge, thinking about and shifting the framework for whose evidence we consider to be real, what we consider to be quote unquote rigorous research. And I think we're slowly getting there. But we're pushing back on, traditions that have been so deeply cemented and ingrained and how we've all been trained, right, to do research, certainly. And so, I certainly am grateful for folks like Dr. Chandra Ford and, the work she's put forth on public health critical race praxis, and others, who have come before me that have created this space to really reimagine what research looks like and what evidence can be brought to bear. But Dara, I don't know if you have.
Absolutely agree. And you're giving me kind of the historical kind of, if you will, connection and flashback to some of the first Black epidemiologists who were saying racism, not race, right? 30 years ago, the Dr. Jenkins and Rowley's and others, and in their context, pushing forward, many who have trained us, and obviously 3-4 decades later, we're still pushing the envelope. And so I want to give you the last word and just kind of a final question. You talked about obviously outcomes from the larger structure, right? That this really speaks to not just the individual physician, but the larger structures in which they operate. And you talk about disrupting the medical and health institutions. Can you share, just I guess as a closing word, other sort of next steps as we think about structural intervention, as we think about the larger picture, and what others on this webinar need to think about moving forward?
Oh, that's a good question. As it hits
Noted.
the hour. You know, I think what we write about in Stolen Breaths, our 2020 New England Journal of Medicine piece around just, I mean, plain and simple divestment from racial inequities, and really understanding that the system is operating currently as it was designed. And until we divest from that and really intentionally say, like, begin to reimagine what's possible, you know, I think we're at a point where, you know, Band-Aids aren't going to stop the bleeding, and we have to really be intentional and well-resourced to create new models and new systems that serve our communities.
Well, Dr. Hardeman, thank you so much. Dr. Mendez, thank you so much. This is just a taste. These are big issues. We are putting resources in the chat so you can follow up on these studies from our various centers. And so thank you so much. This is such an enlightening and important topic. And we look forward to being with you again. Thanks again to our partners at the Center for Health Equity in the School of Public Health. So long from Center on Race and Social Problems in University of Pittsburgh. Take care.
Thank you.
Thank you.
Thank you. Bye.
Bye.